Good afternoon, everyone. It's a pleasure to welcome you to what's actually the next to last seminar of this series. We have a great speaker today, Taylor Winkleman, who you'll be introduced to momentarily by our student moderator. In case you are new here, the Health in the Public Interest Program is a program that looks at the social and other non-medical determinants of health. And you'll see the URL in the chat and are welcome to use the chat later on for putting comments or questions while Dr. Winkleman is speaking. We'll start out with her talk, which is going to go somewhere between 40 and 45 minutes, I think. And then, and that's after Michaela gives a brief introduction. Once the talk is over, we'll take questions from students and then followed by that, the general audience, and Michaela will be moderating both parts of that Q&A session. So let's move on to the main event here. Michaela, if you'll introduce our speaker, please.
Good morning, everyone. Thank you all for taking the time to join us today. We have a wonderful seminar ahead of us, and it is my honor to introduce Dr. Taylor Winkleman-Cagle, who is a clinically trained veterinarian with a master's in public health policy. Dr. Winkleman served as an AVMA Congressional Fellow and the AAAS Science and Technology Policy Fellowship in 2016 to 2017, focusing her portfolio on foreign relations, commercial and national space policy, science policy, immigration, humanitarian issues, human and animal trafficking, and LGBTQIA+ policy. She has experience working as a consultant with the federal government at DTRA, FDA, DHS, and USDA, as well as her current work in the international community as a consultant at the World Health Organization with a focus on biorisk. She's also worked for the World Food Program and collaborated with multiple international organizations in the course of her work. A decorated combat veteran, she speaks Arabic and Spanish with reasonable degrees of fluency and orders food in French and can greet people in various other languages. Dr. W, as she is known to her students, teaches courses on public policy, international policy, technology in the global arena, and emerging infectious diseases. Her teaching philosophy leans toward the pragmatic skills, and she is the originator of the Beneva Group, a student-directed science policy advocacy organization. When not traveling for work or teaching, she can often be found on a flying trapeze or other aerial apparatus. And now I'm going to hand it over to Dr. Winkleman.
Thanks, Mickey. Hi, everyone. I'm Taylor. I'm going to share my slides really quickly. But thank you all for coming. Thank you for your time and your interest. I am a fairly informal person. I was telling the group that it was a miracle that I made slides for this at all. But I am going to try and get through a lot of what I have to talk about because I want to get to the discussion and your questions. And I am open to questions about what I'm talking about, but also about topics that interest you, career paths, all of those things. So please don't be shy. I love teaching and I love having conversations more than I like lecturing. So this is a little bit different for me. So I titled my talk Misaligned Incentives, the Economics of Healthcare in the Pandemic. But the thing I want you to understand is if you saw the title of this, you probably thought that this was going to talk about how much money we were going to spend on certain things. It's not. This is looking at policy through classical economics, which is actually the analysis of choice. So when you're thinking about an economic decision, you're generally thinking about choice, and there's a lot that goes into that. And I will not have time to go through everything. This is going to be sort of a brief overview and basically to give you a taste of the kinds of things that we talk about in our classes, which are taught right downstairs from the HAPI program, but also just kind of my philosophy when I'm looking at policy and trying to understand policy. I chose the pandemic because it's a relatively concentrated example of a global problem that has local issues that we can deal with and Therefore, we can use this to examine choice at multiple levels. So we can look at choices made by individuals, we can look at choices made by countries or states, and we can look at international choices within the context of the pandemic. I also happen to be an infectious disease specialist and veterinarian, so this just sort of fits what I know and what I talk about. My particular area of expertise these days is something called biorisk, which probably sounds pretty self-explanatory. In my day-to-day work, I look at biorisk largely in the deliberate space, so largely in the bioterrorism space. But what's interesting to me and what I spend a lot of time thinking about is the fact that biorisk, which is largely going to be your infectious disease, at least in my world, is going to be focused on infectious diseases. Whether you have a deliberate, accidental, naturally occurring, which is sort of the traditional spectrum of how we understand infectious disease through the global health lens, the outcome is kind of the same, or at least the worst case scenario outcome is the same, right? And one of the reasons why I sort of love to talk about the pandemic is because the pandemic is a really good example of a worst case scenario. It's not actually the worst case scenario, but it's a pretty good one. So understanding what biorisk is, because why is it different from something like infectious disease risk or something like that? Biorisk is or should imply a measurement. And I'm not going to give you any measurements of that today. But one of the things that we're exploring, because this is an emerging field, is how do we in fact measure risk? And risk traditionally is simply probability times impact. We have lots of questions, and this is all ongoing research. But we have lots of questions about how do you measure probability? How do you measure impact? If you're really interested in measuring probability, I can give you some bonus homework, some bonus content, and that is to direct you to the Carey Institute, which is actually based up in the Hudson Valley, which is pretty close to where I am right now. A researcher by the name of Barbara Hahn does a lot of really incredible work on using emerging tech like AI and machine learning to be able to predict things like global hotspots for emergence of new infectious diseases. It's very, very cool work. It is work that we are looking at incorporating into what we're doing, but it's just something that if you're interested, you can go there. Infectious diseases are also unique because you don't have to do anything for them to be a danger, right? If you're looking at, because I look at bioterrorism, infectious disease agents are considered weapons of mass destruction, right? But other weapons of mass destruction generally have to be deliberately made. You don't accidentally make sarin gas, right? You don't accidentally make a nuclear weapon. Those things have to be made on purpose. You can accidentally make an infectious disease, right? You actually don't have to do anything to make an infectious disease. Mike Ryan, who is the Associate Director General of the WHO, once heard in a meeting, one of us, possibly me, say Mother Nature is the best bioterrorist because the world is her lab bench. And he started quoting me on that, which was kind of fun. But also it's an important point for us all to understand, right? We don't have to do anything for this to be a danger. And things can happen at any time. And I know you all know that because I know you all have lived through the pandemic, right? And of course, who is in danger is everybody. And that's one of the most important things, right? If you have other weapons of mass destruction, their area of impact is going to be contained. You can't as easily contain an infectious disease risk. And one of the things, if you start going to global health or biorisk or biosecurity conferences or meetings, one of the things you'll hear is that an infectious disease can get anywhere in the world within 36 hours. And the first time you hear it, it's a really impressive statistic. And the 18th time you hear it, you kind of get tired of everybody making the same point, which I just made anyway. But that's why I work on what I'm working on. And that's why this is sort of a unique area to work in. All right, so that being said, I want to focus a little bit on COVID. And we need to understand the impact of COVID so that we can start asking the right questions, right? So This is accurate to 2 weeks ago. I pulled this off of the KFF website, but they pulled from Hopkins, and Hopkins pulls from WHO. So 777.7 billion cases. 1 in 8 people in the world has had COVID. It's a pretty important, pretty big deal. It's not as big as, say, tuberculosis, which 1/3 of the world has had, but it is more novel, and it is something that is more on people's minds. It has caused 7.1 million deaths, and 1 in 7 of those happened to an American. And it has cost the world $16 trillion so far. It will continue to cost us money. Those estimates are going to start getting more estimaty and less specific as time goes on. In the first couple of years of COVID, there were dashboards everywhere. You could go on the Hopkins website and see all of these very cool dashboards that would tell you exactly up to the minute what was going on. And now they're updated once a week or every 2 weeks. Pretty soon it's going to be once a month. And our ability to collect and process data in the way that we were able to in the first couple of years of the pandemic is sort of deteriorating now. And it's easy for me to go off on tangents. I'm going to go on one on purpose in a minute. But it's important for us to understand that these impacts are going to start being less specific or less easy to understand. And I want to draw your attention to this other statistic that I have up here. 68% of excess deaths from COVID occurred in just 10 countries. This is the planned tangent, by the way. That sounds really important, doesn't it? That sounds really dangerous. That sounds like something we need to be paying attention to. That is, in fact, a direct quote from the WHO webpage on COVID. One of the things that we need to recognize, and let me tell you really quickly, excess deaths are measured by WHO as a deviation from the expected deaths, which are also measured by WHO. And that's the way that we actually, at WHO, we look at the impact of COVID. So there are the deaths that occurred directly from COVID that are where COVID's on the death certificate, but there are other deaths that are attributed essentially to the impact of the infectious disease that's overwhelming health systems, making people seek less healthcare, things like that. So that's how the excess deaths are measured. Now, 68% of excess deaths in 10 countries sounds important, but context is really, really critical. And so often when you see a statistic like that sort of sitting and floating on its own, you've actually missed something really, really important. So over here on the left, we've got the first 2 years of COVID, the excess deaths measured by WHO in the top 10 countries. And on the right, I have shown you the rank. In other words, if you listed all 196 member states of the WHO by the number of expected deaths, every single one of those top 10 countries is in the top 25, right? So what's interesting about that is that it's not surprising that 68% of excess deaths occurred in just 10 countries. Because if you look at the countries up there, a lot of them are countries that have high populations. You expect more deaths out of countries that have higher populations, right? What's more interesting to me are the countries that aren't in those top 10, aren't in that list, right? Because the statistic of 68% in just 10 countries is less significant when you realize that 1 in 8 people in the world lives in China and roughly 1 in 8 people in the world lives in India, right? But you might notice that China is not on that list. In fact, of the top 25 countries ranked by expected deaths for 2020 and 2021, 2 of them, China and Vietnam, actually had negative excess deaths. And in other words, they experienced fewer deaths than we expected to see. Japan had fewer than 200 excess deaths. It is also in the top 25 of expected deaths. That is actually the story that's really interesting to me. That is the thing that draws my attention, right? And that is the thing that I wish I could give you a lot of insight. I'm actually doing the research on it right now to understand and get to the bottom of why did that happen. There's lots and lots of reasons. This is not a single factor sort of answer, but it is a really fascinating thing to start thinking about. And so I have one more slide for my tangent. The thing I want everybody to take away from this is that our insights come from asking the right questions, right? when you are presented with a piece of data or a statistic that seems to have meaning, asking the right questions about that data is going to get you some really interesting and important things. So the first thing I want you to recognize is that numbers are meaningless. Ultimately, I can make a statistic mean whatever I want based on the way that I present it. There is no sort of objective truth to that unless I give you the full picture of everything that's going on, which takes a lot of time, right? Everything is kind of a model. And so this is a snapshot of some research that I'm doing, some very initial analysis that I'm doing. What this is a comparison of the expected number of deaths based on the percentage of those expected deaths that would have been women. In other words, I'm going to tell you right now, if you expect women to be 50% of deaths, or 51% of deaths, you're actually incorrect. On average, about 54% of annual deaths are men and 46% are women. Everything globally is measured on the binary, by the way. Transgender, sexual, gender minorities are often not included in global statistics. That's a whole other thing that we can talk about another time, but it's kind of frustrating to do that as a researcher and work with that. However, looking at this in a binary way, there is variation across countries, but in general, you can expect more deaths, slightly more deaths will be in men than women. Men have a slightly lower global life expectancy than women, right? So what's interesting to me is to ask not what are the numbers, but what is the deviation from normal? And that is where I am very, very grateful to WHO for measuring the expected deaths, right? As it turns out, they tend to be, expected deaths are measured as how many deaths you would expect to see in a country in normal or non-crisis situations, right? So if you have, for example, a war going on in your country, a conflict or civil war, that's not a normal non-crisis situation. And so you would measure excess death based on that. But these are pretty accurate because they follow the laws of large numbers. It's very difficult to tell you what specific people will die, but it's pretty easy when you have massive numbers like 8 billion to be able to say roughly this many people are going to die and this is where, and this is going to be the relative ages and genders. So that's a really fascinating sort of piece of work, and it's very helpful that the WHO puts that out there. So what I like to do when I'm presented with a statistic like that 68% is to say, okay, what's the deviation from normal? So I look at the share of expected deaths for women versus the actual share of expected deaths that we saw in 2020 and 2021. So across those two first years of the pandemic, looking at that, what we see is, and Adam, please feel free to tell me if you've ever seen an R-squared like this on any correlation you've ever run in your professional career. But I've never seen an R-squared of 0.885. And for those of you who are not stats nerds and don't do correlations like this a lot, this is the level of fit or agreement that your trend line has with your data. So when you plot all your data on a scatter plot like you see on here, basically what percentage of your dots or of your data points fit on that trend line. And a good one for me would be like 0.5. Adam, please feel free to tell me if like what you consider good. But in real world data, a 0.88 is unheard of for me. And if you look at I did y equals mx plus b just to make it simple for those of us who remember the equation of a line. The m, the slope of the line, that's so close to 1-to-1, right? The agreement between these two things, and you are measuring apples to apples here, right? But the agreement between these two things is stunning. And so while I can't give you a full conclusion, what I can tell you is that this is a highly predictive statistic, right? Even though this is during COVID, even though we have an unusual or emergent situation and we're measuring excess deaths, the distribution of those deaths, at least along gender lines, is exactly what you're expecting to see, or very close to what you're expecting to see. You see that one deviation, that's Andorra. So yeah, that one's Andorra. There are a couple of countries that did have to be excluded because, and And those are San Marino, Tuvalu, and Vanuatu. And if you know what those countries are, they are small island nations. They're tiny. They experienced massive excess death from COVID because the number of expected deaths was in the ones or tens in those countries, because they're very small and they have very small populations. And so if you expect to see 10 deaths and you experience 100 deaths, you have wildly different numbers of excess deaths, but you also can have huge variation from what you expected to see. And that's just because you're dealing with much smaller numbers, right? So those are excluded, but there's a very good reason why they're excluded. So we don't have a huge deviation from normal. The other thing I want to, and I'm getting off my tangent really quickly, but the other thing I'm going to give you here is some bonus content. If this is interesting to you and you want to learn more about how numbers are manipulated, how statistics are presented, there's an author out of the UK. His name is Tim Harford. He's written several books. I like them all, but The Data Detective is a fantastic book that I often will assign to my students. He also has the Cautionary Tales podcast, and he did an episode on the Data Detective. So it's 10 easy rules to make sense of statistics. I'm so sorry. It's so cold in here. I'm starting to shiver. So if you're interested, please do that. Now, I want to get back to the economics of choice and what drives choice. And what drives choice in general are incentives, right? The reasons that we have to do something, the reasons that we have to not do something. And those are often the impacts or barriers of doing or not doing a thing, or to doing or not doing a thing. Okay. So the first misalignment that I want to look at is the individual's choice to seek health or ability to seek health, right? And we're going to look specifically at the United States here. We're not going to look at global because every country is a little bit different in how it provides healthcare. But in any novel or re-emerging infectious disease, we usually don't have effective pharmaceuticals. We don't have effective vaccines. So we only have non-pharmaceutical intervention or medical intervention that's sort of general support, right? So going to the hospital and getting like air support, getting intubated if you're having lung issues, if you're having heart issues, getting bypassed, those sorts of things, right? So we have a couple of reasons, a couple of incentives in an emerging infectious disease situation. We want to protect ourselves and potentially we want to protect others, right? And there are two levels of choice here when we're talking about this. We have an individual's choice to seek healthcare or to comply with non-pharmaceutical interventions. And we have the government's choice to provide or facilitate healthcare and to mandate and enforce non-pharmaceutical interventions, right? Now, all of you lived through the pandemic, so I probably don't need to hammer home the point of how much or how little compliance we had with non-pharmaceutical interventions. But the point I want to make here is that when we have healthcare as a commodity, healthcare that's provided in a privatized, profit-driven environment, that means that individual health is considered a personal responsibility, right? Not a responsibility of the government, even though infectious disease is a collective threat. If you are living as a hermit in the woods all by yourself and you don't encounter animals or anything that can be a disease reservoir, you will not get an infectious disease. It's not possible. You have to have a source of infection for it to come. The only way that you would get an infectious disease is if some of the commensal bacteria in your body mutated to become infectious and harmful. That's possible, but it's not terribly likely compared to the exposure to external pathogens, right? So this becomes something that when you look at these things, healthcare provision is going to be looking at keeping costs down. And individual action is also going to be looking at keeping costs down. And it's not even necessarily, I don't want to seek health. Sometimes it's, I can't seek health, right? Or I can't comply with a lockdown or a quarantine because if I do that, I won't be able to afford the shelter over my or my family's head, right? I know I don't need to hammer home these points. I know that you all can think through all of these things, but what we end up with is something that's often referred to as a tragedy of the commons. So when you have something that is a public good with no defined or a poorly defined or incentivized area of responsibility, then, and the provision of that, or the care of that public good is dependent on an individual's responsibility, often you see people starting to say, well, I can't do it, so I'm not going to. And the next person sees that happen, and you start to see a domino effect, right? The next person sees that happen and says, well, if they're not going to do it, then I'm not going to do it. That's not fair. And so on and so forth. And then what's something that should be a public good and that should be everybody's responsibility ends up being ignored or sidelined in favor of short-term or more, I don't even want to say selfish reasons, but individual reasons that are usually quite valid. Okay. I want to move to the global aspect of this, right? Because COVID was global. So I want to look at infectious diseases in general. I hope I've shown you they're not individual problems. This one in particular was a massive global problem. And I'm hoping I'm not saying something controversial that anybody would disagree with when I say global responses to global problems require global governance, right? So when I look at this, one of the things that I've noted in the last 5-6 years of my career is that there's a lot of debate and confusion about the role and the efficacy of the international system. So before we can propose policies, we do have to understand the systems in which those policies work. So I want to talk about sort of 4 questions, and then I'm going to walk you through the UN system a little bit so that we can understand it better. So 1, where is the risk? Hope everybody recognizes the risk is everywhere. Every country on earth experienced COVID. Every country on earth experiences influenza. Every country on earth at some point has experienced tuberculosis. We are re-experiencing things that we thought we weren't going to experience again, like measles. Polio is probably on the horizon. I'm very concerned about that, and I hope you are too. So I think we sort of established where the risk is. Who decides is something that is a very interesting question. And we actually have to understand that. We have to talk about the UN system and how it works in order to understand who decides, right? The thing I want you thinking about for the next few minutes is who should decide? Who should make that decision, right? When do we decide? At what point is something going to be a big enough problem for a global response to be necessary, right? At what point in the development of a pharmaceutical or non-pharmaceutical process should we intervene, right? There are analogous responses that the UN system or that the international system can do that are similar non-pharmaceutical interventions, such as trade restrictions, right? Travel bans, travel restrictions. Those things can be implemented or at least recommended by the UN system. And then how do we decide, right? What authority do we use to make those decisions? Cool. So let's go over the UN system really quickly. The purposes of the UN system, for those of you who don't know the history of it, I do teach a class on this. This is sort of my favorite area of history. The UN system was first agreed to in 1945 in the wake of World War II, and the 4 purposes of the UN system are to secure international peace and security. That's the big one. The UN's biggest claim to fame right now is that for the last 80 years, there has been no nuclear war. No nuclear weapons have been used in the last 80 years, and that is the UN's first and foremost purpose. So it claims a lot of success on that. Good job. The UN mandates relations based on equal rights and self-determination. So every country should have the same rights, and every country has the right to self-determination, right? So the UN cannot dictate to another country what it can and cannot do, as long as that's happening sort of within its own borders. The UN is focused on international cooperation, right? And it is focused on harmonizing efforts. And it does all of these things through 7 principles, all right? The first and foremost principle that the UN operates under is the sovereign equality of all members, right? Every state is its own state, and every state has the ability or it has the right to its own sovereignty. If any of you are thinking about Ukraine right now, you probably should be. Just gonna leave it there. It does ask, I can't say require, it does ask that all members act in good faith. I think we can all recognize that that doesn't happen every day. And it does ask or encourage all members to settle disputes through peaceful means. Again, there's a really interesting question as to why that does not happen. And I will tell you why in a minute. It does ask all states to refrain from threat or force against territorial integrity, political independence of any state. Again, Ukraine is an excellent example of where we're not getting the things that we thought we were going to get, right? And it does ask all members to give the United Nations every assistance. I've never understood SIX. I'm not going to lie. I work with the UN. I work around the UN. I've never understood how SIX is supposed to happen. How the organization should work with non-member states to act in accordance with the principles of the UN when non-member states do not, right? That I hope that's as confusing to everybody else as it is to me. And finally, at the end, and this is the most important thing, nothing shall authorize the UN to intervene in matters that are essentially within the domestic jurisdiction of any state. The important thing to know about the UN is that the UN doesn't actually have the authority to intervene without member state approval. And this becomes very, very murky and very, very tricky really quickly. If any of you are aware of the coup that occurred in Niger last year, when the coup occurred, there were simultaneously, for a brief period, 2 governments in Niger. And if you're the UN, I think the question becomes, at what point do you switch over from dealing with one government, right? The government that was legitimately elected, to the government that just took over. It was a rather violent military coup that took the US by surprise, which was fun. So as you're looking at that, I think it's an interesting question to see when the UN sort of deals with the new government versus deals with the old government. At any rate, the UN could not have intervened in the coup in Niger without the request of Niger's extant government. And again, when there are simultaneously 2 governments, it's a really good question as to how that works. All of this is to say that the principles of the UN essentially hamstring the UN from taking any action that the UN states they themselves don't want, because the UN has to have an invitation in order to do anything. In other words, the UN has only carrots and no sticks. And when we're dealing with something like that, we have to ask ourselves, how then can the UN do anything? But before we ask that question, I'm going to ask you a question. So given everything we've said about biorisks and everything that we've said about the UN system, are biorisks, based on especially on that 7th principle, properly a concern for the UN, or are they essentially within the domestic jurisdiction of states? I'm very much hoping that I've made it quite clear that biorisks cross borders, and therefore they are not essentially within the domestic jurisdiction of any one state. They can cross borders without notice or warning. So I hope that that part of it's clear. The other thing I want you thinking about right now is, if the answer is yes, how much power should the UN have versus what we were just talking about? How much power does it actually have? All right. So the answer to the first half of that question is obviously yes, right? Biological events affect everyone. They don't affect everyone equally. This is the 2020 excess mortality for COVID-19 on that map, right? But if what we're doing puts another nation's security or peace at risk, if what we're doing or not doing, if we're not responding to an infectious disease threat, right? We then have a responsibility by the UN Charter to come together to decide how to mitigate biorisks, right? And no nation, in theory, has a right to undertake putting the whole world at risk through either action or inaction. If you disagree with it, I am so interested to hear. absolutely, totally valid. But that is my perspective, and I should note my personal one. So my second misalignment that I have noted is that this becomes a problem of us versus them. When you are facing an infectious disease threat, right? The things that we're concerned about in responding to an infectious disease threat is our own national security, our own intellectual property, right? Because especially in this country, vaccines and pharmaceuticals, they are intellectual property because they are also under the profit-driven incentives, right? And we innovate, we incentivize innovation, right? So how do we incentivize innovation? How do we incentivize the response to this disease within our own country? And then when we're looking at other states, we're not necessarily concerned about their national security, their intellectual property, or how they're incentivizing innovation. We're concerned about what they're doing or not doing that puts us at risk, right? So the misalignment there is that we are concerned for ourselves about one thing and concerned about what they're doing that's going to impact us. But we're not incentivized to be as concerned about what we're doing that's going to impact somebody else, right? So this is the third misalignment. If you think back to our response through Operation Warp Speed and developing a vaccine, we incentivized innovation. And this was by any metric, sort of astonishingly effective, right? The fastest development of a vaccine in the history of the world. Less than 12 months from beginning to end to develop a vaccine. That was a huge win, right? But in order to do that, we essentially incentivized innovation. We took the risk away from the pharmaceutical companies and basically said, here's the money, go forth and do, and also anything that you're going to want, like the intellectual property, the ability to make money off of it, all of that, we're going to give you. And we're going to give you, if you succeed, advanced purchase, right? We're going to guarantee we're going to buy X number of doses from you, right? We incentivized that innovation because we needed it, but we did not consider at the time equity in that innovation, right? Equity was a later concern. So this map is the distribution of COVID vaccines 6 months after the development of the vaccine. So in June of 2021. And if you compare it to that group of 10 countries, right? I want to draw your attention specifically to South Africa and Egypt, which are in the top 10 countries of excess deaths. Neither one of them had more than about 5% of their populations vaccinated by 6 months. When you compare to China, to Russia, to the United States, to Brazil, right? To Australia. Australia is not in the top 25 anywhere, right? But they got access to more vaccines. And that was largely because they were able to pay the companies directly. They did not have to rely on the ACT Accelerator. They did not have to rely on the COVAX facility, right? So the third misalignment here is that the power to develop and innovate these things is specifically vested in national governments, right? So China developed a vaccine, Russia developed a vaccine, the United States developed a vaccine, Europe developed a vaccine, right? Look at the distribution. It should be fairly obvious what happened there. And so because we have the national governments whose primary goal and primary responsibility is to serve their constituents, we don't have a similar power vested in a supranational government, right? There is no global government. I'm definitely about to show my age, but if you watch classic science fiction from the late 90s or early 2000s, you may have seen a movie called The Fifth Element. And if you saw The Fifth Element, you would remember that there is a president of Earth in that movie. It's a very fun movie. If you've never seen it, just add that to your bonus content. But there is no president of Earth, right? We have the Secretary General of the UN, but the Secretary General of the UN does not have manufacturing and development of a pharmaceutical resource within his power. The WHO does not have that either, right? These are policy organizations that advise and assist, but they don't have their own manufacturing. So this misalignment is a fundamental mismatch between the level of governance that we need to respond to our global problems and the level of governance that actually exists. All right. So those are 3 misalignments I want you guys to know about and to consider. And your last piece of bonus content is a book. I changed the colors on the cover. It's actually orange and blue, but this is a pink and purple presentation. So that's what you get. A book called Mission Economy by an amazing economist named Mariana Mazzucato. She is Italian by birth, and she lives and works in the UK now. And the idea here is to understand that when we're formulating policy, when we're looking at how to incentivize things, we need to take a radically different approach in our thinking and in our development, right? So if any of you have paid any attention to the news, you'll know that one of the biggest indicators of how well a country is doing is GDP, right? GDP is often just sort of referred to also as the economy, right? What that actually means and what that implies is that the economy is the outcome that we measure for our success. What Mazzucato says we should do is recognize that the economy, in fact, should be a tool, not an outcome. And the economy is the means to achieve what it is we want to do, right? So if we want there to be fewer deaths from infectious disease, the economy is one of the tools that we can use to do that. Thank you very much for your attention. I am now very, very happy to take any questions.
So for the questions, we're going to start with students. If any students have any questions, feel free to unmute or type them in the chat. And it can also be related to career-related questions or anything of that sort. I see Hannah has her hand up.
Hi, Dr. Winkleman. Thank you for your talk today.
Sure.
I was wondering, how can we encourage the public to view infectious disease prevention and response as a shared responsibility rather than just a personal one, especially in societies that tend to have more individualistic tendencies?
Someone knows about the Hegstead insights, right? Or Hofstede insights, yeah? So that's a really excellent question. How do we incentivize the public? The first one is to recognize that there is always going to be a difference based on culture, right? As you very, very ably noted, the United States is a more individualistic society than, say, Japan, which is a more communal or community-based society. That being said, the number one thing that we can do is understand why people did not actually follow through with complying with the non-pharmaceutical interventions, because you're not going to be able to change culture overnight. And there's some studies out. One of them noted that people respond based on their perceived level of risk. So trying to appeal to the better angels of someone's nature, as much as that sounds useful and important, is actually not particularly helpful. So one of the things that I think is really important is improved communication, right? As we learned more about COVID, the public got understandably quite frustrated with the public health apparatus in the United States, because it felt like we were giving a lot of contradictory or confusing information. The issue with that is we don't have enough education and enough specific, sorry, I just saw a chat pop up. Enough specific science education in this country to help people understand how we respond and how information changes as something like an infectious disease develops, right? So what we actually need to do is start much earlier and teach people better before an emergency happens, both what responsibility to community is, but also how to understand when risk is communicated to them and how to understand when things change, that this isn't them being lied to. It is in fact us saying, oh, we're learning new things now, and now we're communicating that to them, because we ended up contradicting ourselves a lot as we learned more about COVID. I don't know how many of you remember, but the revelation that COVID was essentially airborne went directly counter to what we initially thought. And so I think better communication is at the heart of how we do that. And that communication has to start with science communication in our education system. Thanks, Hannah.
Are there any additional student questions up, Katie?
Hi. So I mean, we've talked about this a bit before in the past, but like when we talk about how the UN can't really regulate the way that we truly need them to, what are tools though that we can use to try and get us as close as possible to kind of helping with regulation? Kind of maybe just as individuals who are considering kind of policy careers, but then also just what are some things that you think we should kind of push for overall?
That is a wonderful question. Thank you. And for transparency's sake, Katie's taken a few of my classes. We know each other quite well. So one of the things that I think is really important is to recognize that international behavior is basically peer pressure. That's how it functions. I really wish that international law meant more than it actually does, but international law is a set of agreed upon principles that countries sort of choose to follow. But again, the impetus is on the individual country. That being said, one of the things that we've seen come out of the pandemic is moves toward the IPPR, the International Pandemic Preparedness and Response Treaty, which has been delayed multiple times, but is still currently underway and being worked on. When we're looking at that from working in the international space, I think one of the things that's important to recognize is how vital science communication is, and how to talk to people in a way that makes sense to them and that is aligned with their incentives, right? And this is really no different than advocating to Congress or advocating to your local policymakers, your town council, your state reps, any of those. And that all has to do with understanding what are the incentives, what are the things that this person or this government cares about, and how can you understand and communicate along those lines. So for example, if I'm trying to communicate to the United States and I'm a humanitarian, which I am, and I want to talk to them about why it's vital to improve or increase the number of vaccines that are going to, let's say, South Africa. Talking to them about the number of people in South Africa that don't have the vaccine is not actually the point that's going to make the difference there. And I really wish it were, right? That is my incentive. That is why I care. But the reason why the United States government would care is because of the vast economic relationship between South Africa and the United States, the damage that will be done if we continue to refuse or limit travel between the two countries. But the spread of COVID within South Africa, which means it's increasing the risk of it coming back and entering the United States and impacting the United States that way. So essentially, you need to focus on enlightened self-interest, right? Doing good for others in order to do good for yourself or for the interests of the group that you're talking to. And if you can make that argument, if you're lucky enough for those things to align, you can sort of realign the incentives and make sure that that communication has the highest chance of actually impacting in the way that you would hope it would.
And if there aren't any additional student questions, I'm going to do the general audience. I do see a question in the chat from Miss Mara Imparato. Please forgive me if I mispronounced your name. But the question is, do you suppose this tragedy of the common good is happening and increasing currently. What steps can we take to counteract this tragedy of the common good? And are there funders who can assist?
Hi, Mara. That's an excellent question. And tragedy of the commons is something that happens constantly, right? It's something that anybody who's lived in the corporate world and worked in an office has experienced just by walking into the break room and seeing the mess that people leave behind in the kitchen, right? And the frustration of, if everybody just cleaned up after themselves, then the whole space would stay clean for everybody. And right, that is a very quiet, personal example of a tragedy of the commons. But that's why in every single office I've ever been in, there's a sign that says, please clean up after yourself, right? If anybody's ever seen the little donation cup for the coffee, right? Asking everyone to chip in for their coffee. Yeah, Medicaid cuts are also another excellent example, right? As we cut Medicaid, oftentimes what we think about or what we talk about is the impact on the individual, right? This person is losing access to healthcare, but often we don't think about what that does to everybody, the increased risk to everybody else. And I'll be very honest, again, this is my personal opinion, I don't think we should have to talk about that, right? The risk to the individual and the responsibility of the government to care for the people should be pretty obvious. But at the same time, in order to have that discussion, it's important to be able to at least analyze and understand why the government should be incentivized to advocate for or take care of people that they perceive as low power or low deserving, right? There are a lot of stereotypes out there that I don't agree with, but that are out there that paint people who need things like Medicare or Medicaid as undeserving. And so we have to work against that, and we have to work on how do we ensure that everybody understands that this is part of the common good. Part of that, I think, is communicating what the common good is, what a public good is. And one of the most difficult things is if you look up the definition of a public good is the most classic example of a public good is information, right? A public good is something that you can consume, but it doesn't reduce the number or amount that's available to other people, right? So information is one of the few actual pure public goods. Because if you get a piece of information that doesn't deny the information to somebody else, and it can be shared, the internet is a beautiful example of how we share that kind of a public good. Health is an interesting one because health care, by definition, if I'm getting health care from a doctor or a hospital, whatever care I'm getting, the time that I'm getting, the resources that I'm getting, those can't be used by somebody else, right? And so it cannot actually be purely a public good. Clean air can be a public good, is a public good, right? And so we have air standards. When we're dealing with health, it's very difficult because it costs money and it doesn't feel like it costs the same to everybody. And it doesn't feel like everybody is in the same boat. And so communicating that, in fact, we are all in the same boat, and that the provision of healthcare under, let's say, for example, a single payer system, or universal healthcare, which is something that WHO and the UN have been pushing towards for almost 3 decades now. Longer than that, but as an official goal for almost 3 decades under the Millennium Development Goals and now the Sustainable Development Goals. Those are there are very good arguments for why, and especially when you're looking in the infectious disease realm, that becomes part of communicating what the public good is. I hope that answered your question, Laura. Did that? Okay, great.
Okay, we see another question in the chat from Ms. Kim Moon. It says, for the data on excess deaths during COVID that you referred to earlier, China reported fewer excess deaths. Do you feel that data is accurate or the result of deliberate misreporting by China?
That's a very good question. And I am not in touch with any Chinese health officials directly. I have not received or read any reports under that. So what I'm going to say is that it is a possibility that there's deliberate misreporting there. I'm not going to say yes or no on that. One thing I will say is that we saw in the early stages of COVID some pretty harshly enforced lockdowns in China, some pretty heavy quarantine requirements for anybody who tested positive. And we do know that the more people are, or the less people are close to each other, the less spread of infectious disease happens. So is it possible that those numbers are accurate? Yes, it is. Is it possible that they're inaccurate? Yes, it is. And I don't have an excellent way of parsing out how much that is. I sort of have to rely on researchers out of China and out of the region to give me the best estimates that are there in the literature. But you can only do so much with the data that you have. I'm sorry, I can't give you a more specific answer. I really don't know.
Okay, I have one more question from Callie, who is a HAPI student. She asked, do you have any advice for how we can stand out on public health job applications in the current environment?
So the current environment is an incredibly difficult one. When we're talking about the current environment where we've seen a lot of federal employees lose their jobs, what that means is that the market is currently flooded with a lot of people who are looking for jobs and a lot of people with a lot of experience and expertise. And this sort of ends up having a backwards domino effect, right? So people will be scrambling to get jobs, and they'll be, a few of them will get snapped up right away, but the job market can't absorb that many people at that level. So what'll happen is more people are going to start looking at jobs that they're overqualified for and sort of take what amounts to a demotion in order to become employed again. And that sort of creates, again, this backwards domino effect that impacts what everybody's doing. I tell you that to let you know that if you're having difficulty finding a job in the current market, that's what's happening to everybody. And that's not a reflection of you or your abilities. Now, to stand out for public health, one, you're going to have a degree out of Georgetown. That's very helpful. Georgetown's pretty well known in public health. It's a pretty well-known university. It has a lot of value on your resume. I'm not telling you to lean entirely on that, but that's a good thing that you have on your resume and that you can do. There are a lot of sort of resources out there for how do you set up a resume. One of the things that I've noticed is recruiters don't as much like the objective or the purpose statement anymore. They more want to see like a clean resume. The biggest thing that I can tell you is get a super kick butt cover letter set up. And what that means is you have to know who you are. You have to know the value that you bring. So one of the things, you heard in my bio that I'm a former Arabic linguist, right? So one of the things that often goes into my cover letters is some fairly standard language that I've developed over the years that says, the very first job that I had was translation, and I've yet to encounter a job where translation is not a very relevant and even vital skill. Now, instead of translating from Arabic or Spanish into English, I'm translating science into actionable policy and understandable sound bites for policymakers and lay people, right? So now I'm giving you, here's my background, and part of my background that you probably don't think is relevant, and I'm making it relevant. So think about the specific skills that you have that are outside of what's expected, because if you have an MPH or a master's in HAPI, then you have sort of what's expected. Show them what about you is unique and special and that applies to the job. And if you're interested, Callie, please feel free to reach out to me. I'm happy to work with you on that.
Dr. Myers.
Yeah, thank you. And Thank you, Taylor, for this really provocative talk today. Um, I'm going to have to cut out, and you'll be in good hands for as long as people have questions up until as late as 1:15. I have one question before I disappear, which is, you mentioned how GDP is, the economy, or at least, we look at it that way. It's an endpoint that we measure. If you're talking about health, we hear a lot of things about how you can look at health in a society. Some people say infant mortality rates or access to healthcare, longevity you see in various places. What would you say is the equivalent of GDP, or the closest you could come up with it? This is what I would say is a measure of health in a society.
You're going to laugh at me. I think that, and this comes from my master's research. When I did my master's, I looked at what impacted infant and maternal mortality. And I realized, and I did a little bit of subsequent research on this to understand it, but the most impactful thing that you can do to improve health in a society-wide, on every indicator that you could possibly use, is to increase your education of females. The more female education you have, the better health outcomes are across the board for every single person: men, women, children, elderly, everybody. Every single person in society benefits when more women are educated, because there is not one single country on the planet where if women are educated, the men aren't. So that's not that. I'm not saying that educating men is not important, but when you have an educated female population, everything gets better, literally everything. So for me, the thing that I have to hold steady if I'm looking at any other indicator of health is female education. So for me, the strongest indicator of health in any society is female education.
Thanks for that. And thanks again for being here today. And it's up to Mickey and Jenny to carry this on for the next 10 minutes or so, or however long people want to ask questions.
Thank you. Cheers.
I know.
All right. Are there any more I see Mr. John Grogan do you have a question? Yeah.
No, I was just suggesting that maybe some discussion about genuine progress indicators, but I think we've exhausted that maybe. I don't know. Thank you.
Yeah.
All right. Are there any additional questions before we close out? Going once, going twice. All right. Well, if there are not any additional questions, we can go ahead and wrap up. I want to thank Dr. Winkleman again for coming and speaking with us, and thank you all for your attendance. As Dr. Meyer said, we have one more HAPI seminar after this. So if anyone would like to be in attendance, feel free to register. But I hope everyone has a wonderful rest of your week.
Thanks, everyone.
Jenny, do you have anything?
That's it. Thank you all for attending, and make sure to check out our next seminar. We'll resume in the fall after we take a little break for summer.
Cheers, everyone.